Thanks so much for having me. And it's really a great pleasure, at least, to be able to provide this talk here. What we mostly do, virtually. And I just want to share quickly my screen so that we can join this. So I was really impressed by the talks before, on Barrett's esophagus and even, of course, on small bowel endoscopy. And now, of course, it's all about the lower GI tract. So what we can do by using artificial intelligence, maybe to reduce the miss rates of colorectal adenomas and maybe even of the cancers in the near future. So I feel the question at the beginning always is, dear colleagues and dear friends, we should optimize. And why should we optimize? And I feel the question and the answer is very easy. It's both. Because we're missing really a significant numbers of lesions, not only in upper GI tract, what we have learned, even in the small bowel, but specifically, of course, also in the lower GI tract, in the colon. And this was a landmark study published many, many years ago by Doug Rex, but it is a landmark study, and therefore we can never oversight it, because we know from this study it was a back-to-back colonoscopy trial, indeed, that we are missing a significant number of lesions. Up to 30% of lesions are missed by using the standard forward viewing endoscopes, and therefore there is indeed a very strong need, I would say, for both lesion detection and characterization, and therefore a very strong need to use advanced endoscopic imaging modalities. And in this setting, we all know, because we are providing those talks and we have the great European Society of Gastrointestinal Endoscopy, we have many guidelines from our fantastic society, but we are aware of advanced imaging techniques in the field of endoscopy since more than 20 years, maybe even longer, if we're considering how long flexible endoscopy really exists. So we are always on the way to explore new things. But if we look, if those new technologies, advanced endoscopic imaging techniques, are really used in the community practice, then it's not that good, honestly, the results. And this is one of those studies showing it. So if we're using advanced imaging techniques like NBI, LCI, BLI, iScan, FICE, whatever we have, is it really even effective in the community practice? And in this study, 13 gastroenterologists were trained for real-time optical biopsy of colon lesions by using optical chromoendoscopy with NBI, and you can see that only 25% of the gastroenterologists who were trained assessed really the polyps with an accuracy of greater than 90%, and thereby meeting the thresholds as proposed by the ASGE in these previous statements in the preservation and incorporation of valuable endoscopic innovations. So advanced imaging might be effective, but it might be not that effective if we're using it in the community practice. And this is very similar to this great talk of Elena just before, even showing that even for Barrett's, even for non-experts, Barrett's is even difficult for experts, but even for non-experts, there is still a lot of room. And in this context, of course, we're not talking about in the colon about the classical big lesion which is visible by anyone, but we are talking about lesion detection, for example, of those lesions only slightly elevated or nearly invisible lesions. And we're not talking about characterization of the typical classical tubular adenoma. We don't need any imaging, specific imaging for this, but it's much more the colon polyp, and it's not that easy always to identify the type of the lesion and if this is a lesion which would require subsequent endoscopic therapy or maybe even not. And therefore, indeed, it's time for this new revolution in endoscopy. We're always talking every couple of years about totally new revolutions, but this is now a very, very big revolution. And this revolution is now, of course, artificial intelligence, or the CAT. The CAT. So not the CAT, but it's computer-assisted diagnosis. And computer-assisted diagnosis really offers us a lot of new potentials. And this is what I want to share with you in the upcoming minutes. And just to show you how AI works in the lower GI tract, and I've specifically chosen this video here because you might be able to see that this is a colon which is not so well prepared. So normally in lectures we are only showing great videos, but specifically I've chosen this one to show you that the polyp is only detected by the AI system and specifically marked. It's not interrupted by any false positive results with these residual stool components. But AI is really so well trained already nowadays that it's only specifically highlighting the small tiny lesion here in the retroflex mode in the transverse colon. Yeah, and then even when we're doing flushing, we have no false positive results. It's only highlighting the correct lesion. AI is so extremely fast, so we are constantly missing lesions in the lower GI tract. And what we have learned specifically from this big study published in the New England Journal of Medicine a couple of years ago, of course, colonoscopy can reduce the incidence of colorectal cancer. But we have also learned from this big New England Journal of Medicine study indeed that we are not that effective in reducing the incidence of colorectal cancer in the right colon. So we might miss a lot of lesions in the right colon. And the question is, are those lesions maybe only sessile serrated lesions, lesions which are maybe only visible by using really latest high definition imaging? Or is it maybe even because there are so many folds and the right flexure and it might become difficult to visualize lesions specifically in the right colon? So this is an example how fast AI is. And we are here now in the ascending colon. You can visualize the cecum, the ileocecal valve here, and we are now returning the instrument. And I hope you can visualize the sound, okay, you can hear the sound as well, but there is a large lesion here. But I would say this is definitely a lesion which might be relatively easy being missed when we might maybe not so always well concentrate during endoscopy. Yeah, so one of us are doing one procedures, other doing 20 a day. Yeah, but of course we're humans, and humans can miss something. And this is definitely a lesion, although it's a larger size lesion, which might be relatively easy being missed because we are withdrawing the scope, and you can see the fold already becomes visible here. But the computer is so fast, it never sleeps, it's never tired. Despite if we're working at 4 a.m. or at 12 p.m., it's never tired, it's always awake, and therefore it shows us indeed that there is a lesion and we have to take care of. Also, AI for the real-time detection, like in this example, it will help us, what you can see here, to detect residual neoplastic lesion after endoscopic mucosal resection. We have learned, for example, from great studies from Christian's L group already a couple of years ago, by Professor Pohl, for example, that there is a high miss rate or a high residual neoplasia rate after endoscopic mucosal resection. And if we're looking at the mucosal EMR scar, it might be sometimes difficult to identify if there is residual neoplasia present, yes or not. AI definitely is helping us, as you can see here. So it marks the residual neoplasia. And currently there are ongoing studies already showing that even during resection, AI is helping us to show us there is a bridge, there is a little bit of residual adenoma left after we have done the EMR. So we can do immediate treatment without having the problem here of the scar and subsequent treatment. Is it now effective to use AI? And this is one study highlighting, for example, the use of AI in sessile serrated lesions. And you can indeed see with AI in general, indeed, we should have a very, very low false positive frame rate. And also AI is already feasible to detect sessile serrated lesions. Some of the softwares, what we have done in this study, we have used the cat eye. Some of the softwares, because we have nowadays more than 10 different AI systems on the market, are already trained just to detect mucosal abnormalities. So they're not only trained on the polyp morphology in general, but they are trained to detect mucosal abnormalities. And with these systems, we are already able to detect even the classic sessile serrated lesion. And also, and this was a great study published by Cesare Hassan, Professor Hassan, just a couple of months ago. And indeed, he had done a great systematic review and meta-analysis. And I'm so impressed why I'm now presenting you the results of these meta-analyses, because what we have seen in these meta-analyses, and just imagine, please, how long we are talking about artificial intelligence. Not more than 2 years, honestly. Maybe 2 or 3 years. But please have a look. Despite this is such a brand new technology, they were able already to include more than 21 randomized trials with over 18,000 patients. And by doing advanced imaging now my whole life, because I love it, and I love having this opportunity, at least mostly being together with you in person, but now at least here in my office, in the rainy Germany. But I've never seen with a new technology so many new studies coming out in such a short period of time with so many patients being included. And I feel this is really extremely exciting. Of course, for AI, it's relatively easy to be used. So we don't need any learning curve. Even the study, how we're doing the studies with AI is not that difficult. The outcomes are relatively easy. And Elena, you have already mentioned your problem to include patients for Barrett's, although you are the center of Barrett's, of course, in Europe. And I appreciate your work so much, what you're doing. But of course, we do not have this problem for colorectal lesions. So over 18,000 patients with over 21, indeed, not only trials, but randomized trials were included. And what we have learned from this systematic review of Cesare is, indeed, the adenoma detection rate was higher in the detection group with artificial intelligence compared to standard colonoscopy group, resulting in a 55% relative reduction in the miss rate, of course, as well. And very important, because we're always talking about being efficient. What about the time? But you can see the mean inspection time increased only marginally by using artificial intelligence. So indeed, there was with AI and detection, this is what the CADI means for polyp detection, an increased detection of adenomas, not of advanced adenomas. So it's, I guess, not difficult to maybe see the large lesions, although they might be hidden behind the folds or the flexures. But of course, in these meta-analyses, we had a higher rate, maybe of unnecessary removal of non-neoplastic polyps. We are seeing more, we are endoscopists, what we are seeing, and this is not normal, of course, we are resecting, and this might result in this one. And then finally, dear colleagues, why should we characterize? Because even characterization, of course, in endoscopy is of paramount importance for resect and discard strategies, for guiding endoscopic therapy in general to become more efficient. And this is how it works at the moment. So we are doing a real-time study here. So we're inflating air in a non-deflated inflated colon, and the polyp is identified. You're switching the button on the handle of the scope, and immediately you will get the characterization showing you if this is a neoplastic or a non-neoplastic lesion. And this is a tubular adenoma, which is already visible by using high-definition white light, and the computer is immediately identifying it as a neoplastic lesion. So what about a little bit more complex cases? This is very exciting because it shows you that the computer is so well trained even to identify nearly nothing. And this is why I want to show you the video. I see this is such a small and tiny lesion, maybe only 1 or 2 millimeter maximum in size, but you can see, although this is such a very, very small lesion, the computer is already identifying it. Of course, it's a hyperplastic lesion, but I feel it's so impressive to show how effective this computer works. It's really already identifying these nearly nothing appearing tissue here, but it's already characterizing it, of course, as a non-neoplastic lesion. And then also extremely exciting, and this is a video of Pradeep Bhandari, and Professor Bhandari is doing a lot of work with AI as well in general. And what we have learned, even with this system here, that indeed you can see that even sessile-serrated lesions now in this setting, indeed with dysplasia, can be identified not only as a polyp, but also being characterized by the computer system. This is the NEC system here, that there is a high possibility of a neoplasia inside, so we should resect. So the new AI systems are already also identifying this dysplasia in sessile-serrated lesions. And is it now effective? Again, yes or not? And this is a study published a couple of years already ago, 2 years ago, and you can see very good statistical data for both detection and characterization. But I feel what is so much more important for us, and Kostas, you're so much involved in the guidelines of the ESGE, and thanks so much for this very hard work and all your efforts. But maybe this is even something what could be so important for us in the future when we're talking about training, because what we have learned from the studies is then when non-experts are using the computer-assisted diagnosis, they already achieved a similar performance to the experts. So non-experts are becoming maybe closer experts by using artificial intelligence. And at the end, dear colleagues, dear friends, ladies and gentlemen, it's even more. And I call it one-stop CAT. So like for MRI scanning, one-stop shopping, what we know from this topic, now it's one-stop CAT, one-stop computer-assisted diagnosis. And what I mean with this one, and this is only a video at the end of my presentation, this is how we are currently doing already endoscopy in the lower GI tract. So we are now here in the right flexure. So we're cleaning the lens. There is a lesion. It's identified by the artificial intelligence here. It might be a lesion which might be missed. So we can enhance a little bit the tissue to perform a better delineation. Afterwards, we're switching to the characterization mode. Immediately, the computer is telling us that indeed this is a neoplastic lesion which warrants subsequent endoscopic therapy. And you might question yourself how large this lesion is. Is it a diminutive lesion, less than 1 centimeter or larger than 1 centimeter in size? So why we're calling it now one-stop shopping is because the new systems already allow us to do a subsequent endoscopic measurement of the lesion as well. So you can see we can enable a specific laser in this endoscope to perform a good pinpoint here, and then we can use a scale bar or a measurement circle in order to show the size of the lesion. And you can see that this lesion indeed seems to be a little bit bigger already than 1 centimeter. So this is what we now consider to call one-stop computer-assisted diagnosis. So everything in one hand. So the lesion is detected automatically by the system. And then, of course, the borders can be delineated a little bit more enhanced. Just by pushing the button, we can do an immediate real-time characterization, no classifications to learn anymore. And then by using another button on the scope, we can perform an immediate measurement of the size of the lesion as well, and then guide our subsequent endoscopic therapy. So, dear chairpersons, dear friends, dear colleagues, thank you so much again for having me, at least in my office here. I think we have seen that indeed artificial intelligence now allows for real-time detection and characterization of colorectal lesions with an excellent accuracy. So also what we are learning that the new AI systems are already also able to detect and characterize sessile-serrated lesions. I've shown you the videos. Non-experts are now becoming faster experts by using artificial intelligence. So this might become a revolution in training of endoscopy fellows now already, maybe not in the future, but already now. And very exciting to have a look at the ongoing studies, because the new systems will provide much more details on the polyp histology. For example, they will show us if there is an SM infiltration. Of course, we have heard about already the potential on Barrett's esophagus and even gastric neoplasia. And in the colon, at least, even there will be new systems coming out next year, which are already trained to identify IBD-related neoplastic lesions.